Excuse me, sorry, I have two comments regarding the previous presentation. First of all, I'd like to ask, this is Dr. Isa Lutfi, I'm Associate Professor at the Department of Nuclear Medicine, Faculty of Medicine. The first comment is that thyroid cancer is really a disease that requires a multidisciplinary approach, as you saw. And there is a lot of collaboration between the surgeon, nuclear medicine physician, and whoever is going to be looking after the patient in the end, the endocrinologist. So I think it's very important to talk to each other and know what it is, the problem with the how to deal with the thyroid. Now follow up with maybe ultrasound or just ultrasound would not be, to my mind, sufficient for these patients. And now we have trends, especially in nuclear medicine, for molecular imaging. I mean, we're lucky in the first place to have the sodium iodide symporter to show these cancers. We need to make good use of that. Now, I haven't heard anything mentioned about SPECT-CT, for example, and this is moving now into the picture and allowing us to differentiate uptake in the residual thyroid from uptake in the lymph nodes, for example. PET-CT also is adding structure to the equation. So again, when we do FDG CT, PET-CT, we'll be able to see where the abnormalities are. So I don't think it's as simple as it is just to say, okay, we'll be able to follow up these patients with neck ultrasound or whatever kind of other technique. We have to look now into what is available, especially in molecular imaging. The second comment I'd like to make is that the treatment, the low-dose treatment of 30 millicuries is an artificial one created by ourselves and by the regulatory committees that said, okay, you can't give more than 30 millicurie, otherwise you have to put the patient in hospital. So again, we have to look more scientifically at what we're doing and maybe do as one of the speakers recommended, dosimetry to know how much we're going to give the patient. And go further, beyond this 30 millicurie kind of level. To my mind, I think a high dose probably should be given to these patients because we had discussions with the late Professor Paddy on many occasions, and there is really good evidence that the low dose doesn't actually work as well as the high dose. So that's probably a point for discussion again. Thank you.
May I ask the presenters, please, to join to have a seat there, so for any questions to be answered by the entire team.
Maybe. Okay.
Yeah.
Maybe you can take this
I have another question. One is for Dr. Ali. Regarding thyroglobulin, level with the use of Thyrogen, when do you collect the sample? Do you collect it after the second injection, or do you collect it the third day?
Sorry, for the measurement of serum thyroglobulin?
Yes. If you use Thyrogen,
Yes.
when do you collect the sample?
Usually we do it before the collection, just to have before the injection of recombinant TSH as a baseline, okay, and then along with the serum antibodies, and then we do it after the second day after the last dose of recombinant TSH.
Okay, so the day of the second injection.
Yes.
Okay. I have another question. I'm really for Dr. Hajjat. The uptake values that you put along with the thyroid whole body radial scan seems to be a little bit low. here in Cancer Center, we use a margin of 1%. So if it is less than 1%, there is the question of whether to use ablation or not. But the values you put, like 0.01 and 0.0, seems to be a little low with the visualization of some iodine. So I really need to discuss after the session, how do you calculate this uptake? Okay.
Okay, but actually it depends on how you calculate your uptake. And there are different methods to calculate. You can put a ROI, or you can, and as background, you can put a bigger ROI in the whole of the body. It's different. Therefore, we have different values.
The last question is for our surgeon, Dr. Abdullah. I mean, this is a good opportunity for us to a lot of cases of Hürthle cell carcinoma, when they come for follow-up with us in nuclear medicine department, they come with different surgical procedures. Can you just tell us how do you act on these Hürthle, especially with Dr. Nabil mentioning that we stop now the term Hürthle cell rather than to put these subcategories?
You are referring to the Hürthle cell carcinoma have different surgical procedure by different surgeons. Well, I mentioned that the standard for treatment of thyroid cancer is total thyroidectomy and central lymph node dissection. This if the diagnosis is known in the preoperative period or suspected during the operative procedure. So less than that is indicated again, as I mentioned, in certain criteria of low risk, are in order. Otherwise, I think the better approach for thyroid cancer treatment is total thyroidectomy. That's the best, in my opinion, provided, of course, complication does not happen, because it's drastic to live with a twitchy muscle and symptoms of numbness and of hypocalcemia, tingling. These are very distressing. And a surgeon should be experienced enough to preserve parathyroid and manage damaged parathyroid during surgery by autotransplantation.
May I comment on this? Actually, your question is quite a relevant question, because we're dealing with that from time to time. The time that really we're faced with this, with the issue of Hürthle cell, is when really we're dealing with a large follicular lesion that really is patient presented, and the biopsy is showing follicular neoplasm Hürthle cell. And then the question is really, should you go for hemithyroidectomy or should you go for total thyroidectomy? And I think if you go to the literature and you look, there is no consensus on the way it is, because some of what look really as, even after surgery, after hemithyroidectomy, they look as Hürthle cell neoplasm, like benign looking. They do behave after a few years as malignant, and then they have recurrent local disease and lymph node involvement. But there is a paper actually that really did address this issue, and maybe Dr. Nabil can comment on this, is that the use now of molecular markers, especially for the RET PTC rearrangement, seems really to give a quite good indication that if done really on the tissue, or that and is positive, that it will indicate that's the need to go for total thyroidectomy rather than going for right hemithyroidectomy.